Welcome back. Today's session will be a continuation to the topic tuberculosis. In the part 2, we will quickly brush through the definition, symptoms, followed by the control of TB. Tuberculosis is a specific infectious disease caused by Mycobacterium tuberculosis. So we know that TB or tuberculosis is an infectious disease. It is caused by the bacteria Mycobacterium tuberculosis. The picture of Mycobacterium tuberculosis is given here. Then we see the symptoms. The symptoms of TB are high fever, fatigue, weight loss, persistent cough, and the cough contains blood. So there is blood present in the sputum. Night sweats. Okay, what are the symptoms of TB? Fever, fatigue, night sweat, weight loss, cough which is persistent and contains blood in the sputum. To begin with, the control of TB. Tuberculosis control means reduction in the prevalence and incidence of disease in the community. So in TB, what are we doing here? How are we controlling the TB? Controlling TB means reducing the prevalence rate and the incident rate of a disease in the community. What is prevalence? Prevalence is the old cases plus new cases, the total number of cases. And incidents are the fresh new cases of the disease in the community, and we need to reduce these cases. The control measures consist of curative component and a preventive component. So there are two components now. To control, we have curative component and the other one is a preventive component. The curative component comprises of case finding and treatment. In curing, what do? We find the active cases and then provide the prompt treatment to those cases. Then preventive component. How can we prevent the TB in the community? It is with the help of BCG vaccination. The BCG vaccination will be dealt in detail in the upcoming slide. So we see curative component is case finding and treatment. Preventive component is through BCG vaccination. These are the two fundamental components of National Tuberculosis Program. So the National Tuberculosis Program, the two fundamental concepts of NTP is curative component and preventive component. To begin with, case finding. The case, in the first place, the first step in TB control program is the early detection of the sputum positive cases. What we have to do? Early detect. How can we early detect these patients? It is through target group. Majority of the pulmonary TB patients have one or more symptoms which are referable to the chest. So which are these patients? Target group patients whom we have to focus and send for the sputum culture, and case finding has to be done in these patients. Majority will present with symptoms which are referring to the chest, such as the persistent cough, fever. The chest symptoms are the ones which will develop very early. This is the most fertile group for the case finding. So the patients, case finding has to be done in the earliest in these target group. The target groups are those who are having the chest symptoms, that is cough and fever. Persistent cough is the chest symptom. They also present with fever, and then the chest symptoms are developing very early in these patients. They are the most fertile group. Is it clear? Case finding is our first step. And then intensified TB case finding. Intensified cases finding activity is basically a provider initiated activity. So in this, the primary object is to detect the TB cases very early by active case finding in the targeted groups, and so that we can initiate the treatment very promptly in these patients. So even in the intensified TB case finding, it is a provider initiated activity. Okay, it is a provider initiated activity where the case finding is done actively in the targeted groups and we are giving the treatment promptly. Then we move further to the screening strategy. Intensified case finding is including the screening strategies. In the screening strategies, we have community screening and institutional screening. So the community screening, how do we do the community screening? The community screening can be done by inviting the people to attend the screening which is done in the mobile facility, or it could also be carried out in a fixed facility. The invitations may target specifically the people within a vulnerable group. Okay. Then comes the institutional screening. The institutional screening in the healthcare facilities. Systematically, they will perform the active screening of the vulnerable individuals who are attending the hospitals or any other healthcare institution. And this institutional screening is carried out in a congregate settings. Systematically, they will perform the active screening of these vulnerable individuals in shelters, or we will also perform the screening in the old age homes, refugee scans. The active screening is performed in these places, in the old age homes, in refugee camps, correctional facilities, and any other specific locations such as workplaces. The institutional screening is done in the healthcare facilities, okay, especially in the vulnerable groups. Even the healthcare professionals are vulnerable to TB because they are continuously exposed to the patients. Is it clear? These are the strategies which we are using in the intensified TB case finding. We are target group, we are targeted groups are taken into focus, and then the two screening strategies are applied. The community screening, where the mobile clinics are there, which can be situated mobile is moving, they are movable, they shift the clinics from one place to other, then they will cover a population in a community, and then they again shift that mobile clinic to other place. Or there can also be a fixed facility where targeted people will be checked for the TB. And then institutional screening, where healthcare institutions, hospitals, the people who are coming there, the patients, and also the other vulnerable individuals are screened. Moving further to the case finding tools. First comes the sputum examination. Now, the case finding tools. What are the tools which we are using in finding the TB cases? What tools can we use? So the tools include the sputum examination, sputum smear examination by direct microscopy. This is the considered method of choice nowadays. So we see that sputum smear microscopy. Now, how do we collect the sputums? On day 1, the sample will be collected on the spot under supervision. The day 2 sample is sample 2. The patient brings the sample on an early morning. Okay, so we see on the day 1, the sample 1 on spot you collected. Day 2, patient will bring the sample on the early morning. Then we have radiography. Radiography is useful in diagnosis of sputum smear negative TB cases. So you perform the sputum smear, but the diagnosis of the smear was negative pulmonary TB. But now next investigative procedure will include the radiography. It is used in diagnosing of sputum negative TB. It is also used in children. Okay, so radiography what? The chest x-rays. So we see the chest x-rays are useful for the diagnosis of smear negative pulmonary TB, and it is also used in diagnosing the TB in the children. It is not routinely indicated in positive cases. Okay, and also the x-rays are these very valuable tools for the diagnosis of pleural effusion or pericardial effusion. You can see these are very valuable tools, especially in the early stages of the disease when the clinical signs will be very minimum. Just with the help of these x-rays, we can diagnose the pleural effusion, the pericardial effusion in the early stages of the disease. Then comes the culture, sputum culture, necessary for the sensitivity test and monitoring the drug treatment. So we see that the culture, here you can see the culture, a combination of solid media or a liquid media. A combination is used of the solid and liquid media. It is currently the gold standard for the primary isolation of the mycobacteria. What sort of culture? Solid plus liquid medium. A combination of both solid and liquid medium is the gold standard for the isolation of the mycobacterium. A few modern rapid methods are also available. They will include the microcolony detection on the solid media, including the rapid slide culture technique. We have many techniques like septic AFB method, microscopic observation of in-broth culture, and then the Backtect 460 radiometric system. So various new modern methods are available. For what you have to remember here is the sputum culture, it is necessary for the sensitivity test and monitoring the drug treatment. Sputum smear is prepared and examined under the microscope. Is it clear? Then comes the tuberculin test. The tuberculin test was discovered by von Pirquet in 1907. A positive reaction to the test is generally accepted as an evidence of past or present infection of MTB. So, this test was discovered by von Pirquet. Is it clear? Who discovered the test? Von Pirquet discovered the tuberculin test. Von Pirquet. Okay, von Pirquet discovered the test in 1907. So what does the test say? If you have a positive reaction to the test, it indicates two things. It is an evidence, it is a proof that you either had a past infection or you have a present infection of Mycobacterium TB. The tuberculin test is the only means of estimating the prevalence of infection in the population. So what is prevalence? Old plus new cases. So it shows the past plus present infection, right? So this is the only measure to estimate the prevalence of infection in a population. Is it making sense? So the tuberculin test, a positive tuberculin test, what does it show? There will be a raised bump at the site of injection. You can see the raised bump can be seen at the site of infection. It shows that is possible tuberculosis infection. So this possible tuberculosis infection could be present in the past or it is a new fresh infection. It indicates both past and present infection. So the only measure for estimating the prevalence of TB is the tuberculin test. Only 2 tuberculins have been accepted as a standard tuberculin by the World Health Organization. That is, what are the 2 tuberculins which have been accepted as a standard tuberculin by World Health Organization? They are purified protein derivative S, PPDS, and purified protein derivative RT23. Is it clear? Then comes the Mantoux test. The Mantoux test is carried out by injecting 1 tuberculin unit of PPD in 0.1 ml intradermally. So we see in the picture, okay, the next slide you can see the injection. What is it? The Mantoux test. How is it carried out? By injecting 1 tuberculin unit. Okay, it is by injecting 1 tuberculin unit, that is 0.1 ml is injected intradermally. Okay, how is the injection done? 1 tuberculin unit, that is 0.1 ml is injected intradermally. Where is the injection done? It is on the flexor surface of the left forearm. You can see the left forearm here, and also the flexor surface is used in midway between the elbow and the wrist. Here is the wrist and here is the elbow. So in the midway between the elbow and the wrist, the tuberculin unit is injected. Is it clear? We are discussing about the Mantoux test. Where is it injected? On the flexor surface of the left forearm, midway between the elbow and the wrist. The injection should be made with a tuberculin syringe with the needle bevel facing upwards. You can see here the injection. How is the injection given? In a needle which is facing, needle bevel is facing upwards. Okay. Next, when placed correctly, injection should produce a pale wheal of a skin 6 to 10 mm in diameter. The result of the test is read after 48 to 96 hours, but 72 hours is the most ideal time. So we saw in the picture the wheal which is produced. The wheal is produced on the skin, and the result, a pale wheal is produced, and the result after 3 days it is seen. The tuberculin reaction consists of erythema and duration. So the Mantoux test is producing a wheal, okay, a pale wheal. It is producing a pale wheal of the skin which was measuring about 6 to 10 in diameter. And now we see the tuberculin reaction consists of erythema and induration. Since the erythema is sometimes difficult to measure, the induration is measured. So erythema is the redness, induration is the hardness. Induration is the hardness of that wheal, okay? And then we have erythema, the redness. Since redness is sometimes difficult to measure, we prefer to go with the induration alone will be measured. Clear? The reaction exceeds 10 are considered to be positive. The reactions less than 6 are considered to be negative, and those between the 6 to 9 are considered to be doubtful. The reaction may be due to Mycobacterium tuberculosis, or the reaction could be of an atypical mycobacteria. If there is no induration, the result is recorded as nil. So is it clear? What did we understand with this? That the reaction, we are going to measure the reactions. The reactions, first we saw that 6 to 10 in diameter. Minimum it has to be 6 to 10 in diameter. Less than 6 is doubtful, and then if it is more than 10 it is positive. Is it clear? More than 10 positive, less than 6 is considered negative, and 6 to 9 is doubtful. If there has been a further observed that strong reactors, that is those who are showing more than 20 in duration, they have greater chances of developing TB than those who are showing 10 duration. So 10 was 10 duration was, wait, let me write it again. 10 was positive. So those who are showing more than 20 or equal to 20 they are definitive of developing TB. Okay, they are the strong reactors. They have higher chances of developing TB than those who are showing 10 in duration. Moving further to the chemotherapy. So in the chemotherapy is indicated for every case of active tuberculosis. Objectives of chemotherapy include the elimination of both fast and slow multiplying bacteria, and it is mainly the elimination of bacilli from patients who are having sputum positive. So the chemotherapy should be made easily available free of charge to every patient who is detected positive. It should be adequate, appropriate, and it has to be applied to an entire pool of infectors in the community. Is it clear? So the chemotherapy, it is given to every active case. What is the main objectives of this chemotherapy? They want to eliminate the fast and slow multiplying bacilli, and mainly they want to eliminate the bacilli from the patient's sputum. Is it clear? From the patient's sputum, they want to eliminate the bacilli. And we know that it should be free of charge. It should be available to all the patients who are detected. It should be adequate and applied to the entire pool of infectors in the community. Then comes an anti-tubercular drug. An anti-tuberculosis drug should follow some criteria, like it should be free from the side effects, it should be highly effective, easy to administer, and reasonably it should be cheap. Is it clear? the anti-tubercular drugs, which we will discuss in further slides, the various first line drugs, second line drugs. So these drugs, the anti-tubercular drugs, they have to be free from side effects. They should be effective, easy to administer, and reasonably affordable. They should be cheap, and the administration should be easy. They should be effective. Being effective, they should not contain any sort of side effects. Classification of drug. Currently used drugs are classified into bactericidal drugs, which will kill the bacteria, or we have bacteriostatic drugs, which will inhibit the multiplication of bacilli and it will lead to the destruction by immune mechanism of the host. So, bactericidal. Cidal, it kills the bacteria. Is it clear? Bactericidal. Bactericidal drugs will kill the bacteria. Whereas static, static is inhibiting the multiplication. Okay, they were multiplying continuously, so it will inhibit the multiplication of the bacilli. Then once the bacilli's multiplication is inhibited, further the destruction of the bacteria occurs by the immune mechanism of the host. Okay, the immune mechanism of the host is going to destruct the bacilli. Is it clear? Bactericidal will kill, bacteriostatic will prevent the multiplication, further destruction will occur by the immune mechanism of the host. So what are the bactericidal drugs? We have rifampicin, isoniazid. The INH stands for the isonicotinic acid hydrazide. Isonicotinic acid hydrazide, which is nothing but isoniazid, which is ranking among the most powerful drug in the treatment of TB. And then we have streptomycin and pyrazinamide. These are the bactericidal drugs. What are those? Rifampicin, isoniazid, streptomycin and pyrazinamide. Then we have bacteriostatic drugs, that is ethambutol and thiacetazone. Thiacetazone, which we will discuss in detail. Each of the drug will be discussed in detail. So the first line drugs and the second line drugs of the TB. The first line drugs will include pyrazinamide, rifampicin, isoniazid, ethambutol and streptomycin. Where how can we remember? We have a mnemonic priest. Okay, Priest. So P stands for pyrazinamide, R stands for rifampicin, isoniazid, ethambutol, streptomycin. Is it clear? The priest, by the mnemonic priest, you can remember the first line drugs: pyrazinamide, rifampicin, isoniazid, ethambutol and streptomycin. These are the first line drugs. Now we will go to the other mnemonic, which is KTR face pack. Okay, the KTR face pack. So the K stands for kanamycin. Let's see. Okay, KTR face pack or KRT face pack will be however you want to remember. So kanamycin, thiacetazone, rifabutin, fluoroquinolones, amikacin, C stands for capromycin, ethionamide or prothionamide, E stands for ethionamide, and PA stands for para-amino-salicylic acid, and lastly C stands for cycloserine. Is it clear? K kanamycin, T stands for thiacetazone, R stands for rifabutin, F stands for fluoroquinolones, A stands for amikacin, C stands for capromycin, amikacin, capromycin, kanamycin. And then P stands for prothionamide, and we have C. Okay, P stands for prothionamide, or you can remember better E, ethionamide, and PA stands for para-amino-salicylic acid, and C stands for cycloserine. To begin with the bactericidal drugs. First drug we have is rifampicin. Rifampicin is a powerful bactericidal drug. Rifampicin will permeate all the tissue membranes, including the blood-brain barrier and also the placental barriers. So the rifampicin is a powerful bactericidal drug. It has the capacity to permeate. It will enter even the blood-brain barrier. It can cross the placental barriers. It is the only bactericidal drug which is active against the persisters or the dormant bacilli which is found in the caseous lesions. Is it clear? Only bactericidal drug active against dormant bacilli or the persisters which are still present in the solid caseous lesions. All other drugs are being inactive. Only the rifampicin has the capacity to act against the dormant bacilli. Many patients will develop nausea at the start of the treatment, and it is the only oral drug which is available, and then the dosage is 10 to 12 mg per kg body weight. The toxic effects which we were discussing, that many patients will develop nausea at the start of the treatment. The toxic effects include the gastritis, purpura, and the others will include the hepatotoxicity, influenza like illness, thrombocytopenia, nephrotoxicity, etc. So rifampicin, what will you remember about the drug rifampicin? That it has the capacity to permeate the barriers. It is active against the latent dormant bacilli, and the next thing is it has some side effects like hepatotoxicity, influenza, gastritis, etc. Moving further to isoniazid. Isoniazid, the INH, which is also known as isonicotinic acid hydrazide. Let me just write it down for you. Isonicotinic Ni. Okay, isonicotic. We have acid, isonicotinic acid hydrazide. Okay, isonicotinic acid hydrazide, it is the most powerful drugs in the treatment of TB. It can easily penetrate the cell membrane. You can see here, can penetrate the cell membrane, and it is thus active against intracellular and extracellular bacilli. It can also pass through the blood-brain barrier which is present in the CSF. So we see that INH gets widely distributed in the body, including the cerebrospinal fluid. The administration, it is 4 to 5 grams per kg body weight. So we see that isoniazid is very easy to administer. It is free from the toxicity, and also the cost is low. The low cost and freedom from toxicity and the easy administration is making it an ideal component for the drug regimen. Is it clear? Now let's move further to streptomycin. Streptomycin is a less active against the slow multipliers. So it will act more rapidly on the multiplying bacteria, but it is comparatively less active on the slow multipliers. And streptomycin has no action on the persisters. So it has no action on the dormant bacilli which is present in the lesions. Okay, it does not permeate the cell wall. So we see it has it doesn't have much it is not much effective compared to others like the rifampicin and isoniazid. It does not permeate the barriers. It does not act upon the dormant bacilli. It is less active against the slow multiplying bacilli. And the administration, which is nothing but the daily dose of streptomycin, is 0.75 grams to 1 gram in a single injection. It is 0.75 to 1 gram. You can see here it is 1 gram in a single injection. It does not permeate the cell walls. So the normal biological membranes such as meninges, pleura, it has no capacity to penetrate them. Moving further to Pyrazinamide. Pyrazinamide is a bactericidal drug and it is particularly active against the slow multiplying intracellular bacilli. It is active against slow multiplying intracellular bacilli which are unaffected by other drugs. So we saw that streptomycin does not act against the slow multiplying intracellular bacilli, whereas pyrazinamide has the capacity to act against the slow multiplying intracellular bacilli. The drug is given orally and the pyrazinamide achieves high levels in CSF and therefore it is recommended especially in tuberculous meningitis. And the usual dose here we see is 30 grams per kg body weight. Moving further to the bacteriostatic drugs. Can we just quickly go through the bactericidal drugs? What are the drugs we discussed? In the first we spoke about rifampicin, right? We spoke about rifampicin. What did we see about rifampicin? It will permeate the blood-brain barriers. It is a bactericidal drug, especially acting upon the dormant bacilli. Okay, some side effects it includes. Then we saw about the isoniazid, that is INH. INH stands for the isonicotinic acid hydrazide and it is a powerful drug used in the treatment. It is active against the intracellular bacilli plus extracellular bacilli. It also penetrates the cell membrane and it also acts upon the CSF. So all the plus points we saw about INH. And then we discussed about the streptomycin. Streptomycin is not active against the slow multiplying bacilli and then it does not penetrate the membranes like meninges or pleura. So we saw those and it does not act upon the dormant bacilli. So streptomycin has three negative points, you can say. Not negative, but it does not act compared to the other two. And then we saw the fourth one was pyrazinamide. In the pyrazinamide, it is active against the fourth we saw was pyrazinamide. In the pyrazinamide, we saw the pyrazinamide is particularly active against the slow multiplying bacilli. Okay, and it is given in tuberculous meningitis. Now we will move further to the bacteriostatic drugs. The bacteriostatic drugs include the ethambutol. Ethambutol is used in combination to prevent the emergence of the resistance to other drugs. It is usually given in combination so that we can prevent the resistance to other drugs. It is usually given orally. The major side effects will include the retrobulbar neuritis. This however does not occur at the usual dosages. It does not occur usually when it is taken in a higher dose, in a more doses, then only it results in the retrobulbar neuritis. The dose used here is 15 mg per kg body weight. It is given in 2 to 3 doses. The second line drugs, what were those? They are fluoroquinolones, ethionamide, capreomycin, kanamycin, amikacin, cycloserine, macrolides. So let us discuss about the fluoroquinolines. So the fluoroquinolones include the ciprofloxacin, ofloxacin, levofloxacin, moxifloxacin and gatifloxacin. They are active against the Mycobacterium tuberculosis and even those resistant to other drugs. So even if the Mycobacterium tuberculosis is resistant to other drugs, the fluoroquinolones will be active against them. They are given orally, or the fluoroquinolones can also be given IV. They are useful in treating the infections which are resistant to standard drugs and in cases with the relapse. Is it clear? We are discussing about the fluoroquinolones. So these fluoroquinolones are including the ciproflox, oflox, levoflox, moxiflox, gatiflox. So they are active against the Mycobacterium TB which are resistant to other drugs. They are also used in cases with the relapse. You can see in the picture ciproflox, levoflox and moxiflox is given. Then comes ethionamide. Ethionamide is effective against the bacilli which are resistant to other drugs. It is proved effective in infections due to atypical mycobacteria. So certain infections which are positive to the sputum smear, but the typical mycobacterium is not the causative factor. We have atypical mycobacteria. So the ethionamide is effective against those bacilli which are resistant to other drugs in the first place, and also it is effective in those infections which are caused by the atypical mycobacteria. It is effective against the intracellular as well as the extracellular organisms. Is it clear? Ethionamide is active against bacilli resistant to other drugs and also atypical mycobacteria. It will act upon both intracellular and extracellular organisms. Then comes capreomycin. Capreomycin injection is used together with the other medicines to treat the TB in patients who have received other medicines and yet it did not work well in them. And capreomycin is a bactericidal drug. Its mechanism of action, pharmacokinetics and adverse reactions are similar to those of streptomycin. So again, what did we study about streptomycin? We saw that the streptomycin is also a bactericidal drug. It acts upon the rapidly multiplying bacilli. So the mechanism of action, again, it is bactericidal. It kills the bacteria. And less active against the slow multipliers. It has no action on the dormant bacilli. It does not permeate the normal biological membranes. So the mechanism of action, the pharmacokinetics, adverse reactions. So what were the adverse reactions? We saw certain toxicities. See, just like in isoniazid we saw the toxicity. Here streptomycin can also result in the drug toxicity. Then these are similar to streptomycin. Capreomycin is similar to streptomycin. Then comes amikacin and kanamycin. Kanamycin and amikacin they are bactericidal and active against the bacilli which are resistant to streptomycin. So first we see the streptomycin is not able to act on these bacilli. Then we move further to provide the patient with kanamycin and amikacin. They will be active against the bacilli which were resistant to streptomycin, to isoniazid and cycloserine. Then we have cycloserine. This drug is mainly bacteriostatic. It is effective against the bacilli which are resistant to isoniazid or streptomycin and against the atypical mycobacteria. It acts by inhibiting the synthesis of the bacterial cell wall. So it acts upon the multiplying bacteria. It will prevent the multiplication of the bacteria. It will initiate the immune response to act against those bacilli. And then see, it is a bacteriostatic drug. It will act upon the bacilli which are resistant to other drugs. Then we have thioacetazone. Again, it is a bacteriostatic drug. It will rapidly diffuse in the various body tissues. It crosses the placental barrier. It is also secreted in milk. It should never be used in HIV patients as it can cause the severe and fatal skin reaction. So we see that the thioacetazone should not be used in HIV infection because it can result in adverse effects, like it can cause the skin reactions, severe fatal skin reactions, and it can result in the various side effects like gastrointestinal disturbances, gastritis, blurring of vision, hemolytic anemia and urticaria. Is it clear? Thioacetazone, which is a bacteriostatic drug. It crosses the membranes, placental barrier, and then not given in HIV because of the adverse effects. Side effects were gastric complaints, vision is affected, blurring of vision occurs, anemia and urticaria. Then we have macrolides. Newer macrolides, azithromycin, clarithromycin, also have an action against the tubercular bacilli. They are used to treat atypical mycobacterial infection and those cases with relapse. Then we move further to bedaquiline. Should we revise it? Macrolides. What are macrolides? They are azithromycin tablets, clarithromycin tablets. They have shown to have action upon the tubercular bacilli. and these act upon the tubercle bacilli and used in cases of atypical mycobacterial infections as well, and also those cases which are having a relapse. Then we move further to bedaquiline. So, bedaquiline BDQ, bedaquiline, the abbreviation BDQ, specifically targets the mycobacterial ATP synthase, which is an enzyme essential to supply the energy to mycobacterium. So once the energy is not supplied, so the bacteria dies. So bedaquiline will target the ATP synthase, which is responsible for providing the energy to mycobacterium. It is a bactericidal drug which has extended half-life, which measures that. What does it mean, extended half-life? First, it is a bactericidal drug. It has an extended half-life. What do you mean by extended half-life? It means that the bedaquiline is still present in the plasma up to 5 to 5.5 months post stopping the bedaquiline. So, any bacilli which is still present, it can act upon it. Once you have stopped the drug, it still have an extended shelf life. It is still present in the body. Its effect is still present in the body, and it can kill the bacteria. Moving further to 2 phases chemotherapy. It is well recognized that there are 2 phases in effective treatment of tuberculosis. The first phase will be short, aggressive and intense phase, which is lasting for 1 to 3 months. So we see that the first phase, which is a very short, aggressive and intense phase, it is seen early in the course of the treatment, and this treatment will last up to 1 to 3 months. During this intensive phase, 3 or more drugs are combined to kill off as many bacilli as possible. So what do? 3 drugs or intense phase. Okay, the first phase is a short phase, very intense, very aggressive. We are using 3 drugs or more than 3 drugs. We are killing off the bacilli as much as possible. So the more rapidly the bacilli are killed initially, they are less likely to emerge again. So the more rapid you kill, less likely that they will persist or they will emerge. The risk of relapse will be reduced. Then comes the second phase. The second phase is the continuation phase. In the continuation phase, it is aimed at sterilizing the smaller number of the dormant bacilli or the persisters which are present. We are sterilizing the small number of the dormant bacilli or the persistent bacilli which are present. And this phase, the duration of the treatment is not less than 18 months. So here the duration of the treatment in the standard anti-tuberculous therapy, we see that the second phase, it is not less than 18 months to achieve the complete sterilization of the bacilli. So we see with the introduction of the rifampicin and pyrazinamide, this period of 18 months has been successfully reduced to 6 to 9 months. Is it clear? Then we have DOTS. In DOTS, what does DOTS stand for? Directly Observed Treatment Short Course. In Directly Observed Treatment Short Course, which is a strategy to ensure the cure by providing the most effective medicine, and we are confirming that the medicine is taken. The drugs are provided in patient-wise boxes with sufficient shelf life. So we see that in DOTS, during the intensive phase of treatment, one health worker, you see in DOTS what's happening? During this intensive phase of the treatment, the health worker or a trained person will watch as the patient is swallowing the drug in his presence. He will watch the patient that he is swallowing the drug. During the continuation phase, the patient will be issued a medicine for 1 week in a multi-stabilizer combi pack, of which first dose again will be swallowed by the patient in the presence of the health worker or the trained person. The consumption of medicine in the continuation phase is checked by the return of the empty combi pack. Okay, we see that it is provided in the drugs are provided to patient wise in boxes. So the boxes are nothing but those combi packs. Okay, in the continuation phase, once the patient returns back with the empty multi blister combi pack, so this multi blister combi pack which is emptied shows that the patient has taken the medications. When the patient comes to collect the medicine for the next week, you will check the box. The drugs are provided in patient wise boxes with the which are having a sufficient shelf life. Okay, is it clear? Then in the next part we will discuss about the childhood TB, and then we will discuss about the vaccine, BCG vaccine, the pregnancy, TB in pregnancy, and also the resistance, the primary resistance and the secondary resistance. So let us stop here, and the remaining will be done in the part 3 of the tuberculosis. Thank you. With this, we come to an end of today's session. If you like the video, hit the like button and subscribe.